Thanks, Michelle, and thanks to ImpediMed for inviting me to speak about the bilateral SOZO application. For those who don't know me, I'm a physiotherapist and I've been working in this area since 1991. So I've seen lots of changes that have occurred with objective measurements. But objective measurements with the SOZO are just part of the toolbox that we've sort of explored over the last couple of webinars. It's not something we would just take on its own. So it's still important to look at your objective assessment, your subjective assessment, look at your observation, look at your palpation, take your circumference measurements, whether it be by tape measure or by a pyrometry or whatever it is, so that you can get a picture. But the SOZO by impedance allows you to see the inside and give you some other information that will assist you with your clinical reasoning. When SOZO came, it was very exciting because it was quick and easy, and it also gave us that ability to start looking at other things such as fat mass, muscle mass. As a physio, muscle mass was really exciting. It also allowed us to start thinking, okay, so what about bilateral application? So like many therapists, we started saying to ImpediMed, when's bilateral coming? When's bilateral coming? So in 2018, it was so exciting because it opened us up to look at lots of our clients, and really pretty much all our clients can actually be assessed by the SOZO. So let's have a little look at what this bilateral application actually can help us with. So like the unilateral application, the clinical use is similar. So you are looking from a surveillance perspective. So like unilateral, you hope to monitor someone that's at risk, whether it perhaps is breast cancer in regards to maybe it's an axillary clearance on one side and a sentinel node biopsy on the other. So that's a bilateral application. Or it's, in our area, we see a lot of gynecological cancers, so where they've had pelvic lymph nodes removed or radiotherapy to the pelvis. So both legs are at risk. So that's an area that still exists for a bilateral application. Of course, the lymphedema assessment and then management and the effects of the management on our objective measurements. Then the next sort of areas are pretty unique, I think, to the bilateral application. So your mixed vascular lymphedema, which is often bilateral, your lipedema or your lymphedema. So you might be exploring how much fluid is there, but also looking at all those other issues such as fat mass, muscle mass, as looking at the whole person. And there's more research to come in that area, so watch that space. And then increasingly we're seeing obesity-related chronic edema, where in the lower limbs mainly, where you're seeing a large abdomen pressing on those inguinal nodes and causing edema in the legs. And it's a difficult area to manage, but it's also an important one, especially not just looking at the fluid, but looking at the muscle mass, looking at the fat mass, and trying to get the best management for that person. So from there, there's a wealth of knowledge that we can get from the SOZO, and I probably don't even utilise it enough. So the areas that I look at this point in time is the fluid, the skeletal mass, fat mass, some of the other areas as well. I never look at BMI. I just think it's irrelevant. You know, the weight and the height, what does that really mean? Because it's not breaking it down into the various components. And it's a shame that a lot of the research is hanging itself on BMI. The other area which I'd like ImpediMed to explore a bit more is about the bone health, not only from the perspective of the impact of cancer treatments on bone, and therefore we can look at exercise and whether there's other medical management that needs to be looked at, but also from the aging population, the osteoporosis, etc. Hopefully there's some future that we can look at assessing that, so we're looking at the total person. With all that information, you need to know, well, how are you going to manage that? And that brings me on to having a really strong multidisciplinary team. And I've put the question marks because it really does depend on the person and what they present with, who you choose on that multidisciplinary team. So the success is, I think, of the management, and in that team is obviously the client, is having a strong referral basis. So I'm a physiotherapist, I'm not a podiatrist, I'm not a psychologist, so I need to refer out. For others, exercise may be not in their scope of practice, so referring to an exercise physiologist or a physio is important. So psychologists, your social workers, your occupational therapists, have that team, and you all know about that. That's important to have that strong team. So if we have a little look at surveillance, I'm pulling on some of the information that Louise Kohlmeyer explored a couple of webinars ago. It's very similar for a bilateral application. So ideally, we'd see them before the operation and get some baseline measurements and do the education and say what's going to happen moving forward. That doesn't often happen. And I'm in private practice, and we just often don't see those people for various reasons that have been mentioned previously. My question is there another way of looking at it? And Sheila Ridner, who is based in the States, has explored, and I assume she's still looking at, is once you hit 6.5, can you then say there's evidence of lymphedema, and you could use that as a bit of a surveillance measurement? And perhaps Rochelle or anyone else that's on the panel could explore that a little bit more after the webinar to see where we're heading with that, because I actually don't know the answer to that. Of course, as part of surveillance, we're looking at ongoing education, and you've got to say that many times in regards to education. It's not just about their lymphedema risk, it's about their strengthening, getting them back to normal, looking holistically. So that rehabilitation, that strengthening process, especially with lower limbs, looking at the balance issues, monitoring that, and then of course early intervention. So if you're looking at obviously lower limb, it's the same situation, or bilateral, obviously arms, is that you want to intervene early with compression, class 2 compression. So similar to a unilateral, you are looking at surveillance over a couple of years at that sort of 3, 6, 9, 12 months, etc. time frame. So I want to explore this surveillance / management with a couple of case studies, because they're a bit of a combo. So if you look at this lady, she's 77 years old. She'd had in 1992 a radical hysterectomy and radiotherapy for cancer of the uterus. In 2002, she developed lymphedema in the left leg, and the right leg sort of swelled off and on over time. It was influenced by summer versus winter. It also was influenced by her weight. And her management pretty much has been compression garments. She likes pantyhose, she likes circular knit. Class 2, she probably would do better with a flat knit on her left leg, but in her eyes, there's also that view of the way it looks, and she's done really well. She is active, she is not overweight. She is careful, she does her exercises, she does self-lymphatic drainage, she's really careful, she goes to the podiatrist. So overall, she's doing really well. So if we have a little look at her measurements, on the right leg, there's no issues at all. That's floating along. She's quite keen to watch that and monitor that. And her left leg is pretty stable, as you can see, not very high measurements. And you might say, oh, that's really interesting, because it looks quite swollen compared to the right leg. And you've got to remember, though, she's had it for a very long time. So there is changes, and there's changes to increased adipose tissue. So when the measurements don't add up, sometimes we blame the actual machines that we're using, and rather than thinking about what's going on and making sense of the information. This lady, once again, is a surveillance management issue. So age 64, September 1995, she had a left partial mastectomy and axillary lymph node dissection. 1 out of 28 nodes were positive. She had radiotherapy to the breast, and she developed her lymphedema in her left arm in 1997. In June 2007, she was unfortunate to get breast cancer recurrence, and she underwent double mastectomy, a right axillary lymph node dissection, which she was really upset about, because she said, I can't get another swollen arm. I can't manage compression garments on both arms. And she also had chemotherapy. And as you can see, her right arm is not really, and it hasn't been an issue. Her left arm is. Her main swelling is below the elbow and significant on the back of the hand. And there is pitting edema there. She has been wearing, she's had numerous forms of management, but has been pretty much since 1997 wearing a flat knit compression garment from the base of her fingers up to her axilla. However, over the last couple of years, we've explored in winter just up to her elbow because her upper arm is not a major issue. And so that's been useful for her as well. So for her, having surveillance, and we started obviously in 2018 when I had that ability to do that, is she was keen to look, you know, we were always measuring with the circumferences, but she was keen to know what was going under the surface of the skin. And you can see what the right arm is traveling okay. So that reassures her. She wasn't that keen on looking at body composition because she's a bit overweight and she knows what she needs to do and she is trying hard, but she was very keen on the L-Dex history. So if we have a little look at her left arm and we just remember where the problem is, so it is mainly in the forearm and the back of the hand. I want you to have a little think, what sort of L-Dex measurement would you think she might have? Is it 20? Is it 30? Is it 25? 15? What do you think might be? So let's have a little look. So it's quite low and it is fairly stable. And you might go, that doesn't make sense, you know. It should be much higher than that. And there's a couple of reasons. One, which I talked about with the other lady, that it is a very long time. So there has been conversion across to fat, to adipose tissue. The other thing is that hand is not being captured overly well with the SOZO, the swelling on the back of her hand. So that is watering down a little bit, the measurements as well. But it doesn't matter. One measurement is, you never look at one and make a statement on it or make a decision on it. You actually look over time. So we're heading still in the right direction with her. So when we look at the numbers, and if they don't make sense, you need to question why. So this lady is a fairly recent lady I saw who had a sentinel node biopsy on the right and axillary lymph node dissection on the left. She had double mastectomy as well. She had also undergone chemotherapy. So I got her set up for the SOZO, putting all in the information, said, oh yes, we can do bilateral, and then straight away made her a unilateral profile. Silly me. So I did the measurement, 24. Seems fairly reasonable. I said, oh, I'm terribly sorry. Yes, we want to be able to monitor and do surveillance on the right, so I'll make you bilateral. And then it spat out 8. So why do you think that's occurring? Why 8 when it was, you know, 24 with the unilateral? Any ideas? Well, I actually asked her, have you got any swelling in your feet or your ankles? She said, oh, yes, I have. I had chemotherapy and I've got the peripheral neuropathy and I have had some swelling in my feet and ankles. Not that I look down there much, but I have had some swelling. So I explored a bit more and sure enough, pitting edema in the feet, the ankles, and halfway up her tibia, the lower leg, there was swelling. So that was washing out those measurements. All right, and if you don't understand that, perhaps put that in the questions and perhaps Rochelle can explore that a little bit more later on. So yes, we can use it for assessment and management. This is a straightforward case where you've got someone who's 52, obesity, recurrent cellulitis, mobility issues, and obviously quite significant swelling in his legs. And it obviously went down a lot with massage, bandaging, compression pump, and he was to be fitted for compression garments, flat knit compression garments. So as you know, when we're looking at those sort of reductions and the numbers don't surprise you, that makes a bit more sense, doesn't it? The 39.6, and obviously the right was worse with 53.7. We're looking for a plateau before we measure for a compression garment. Otherwise, the garment may not fit correctly. We can do a little bit of fiddling with the numbers, but we try and get as much as we can reduced. So we actually measured first on the left, and I held off slightly on the right to get a little bit more reduction from 17 to 11.5 before we measured for the right, and then he was fitted into compression garments. So circumferences reduction, you know, you're looking at your 20 centimetre reduction is great, but he was also keen to see what was under the surface of his skin and what was going on. Wasn't that keen necessarily on the fat mass and the muscle mass, but that's another story. Chronic edema is common in the elderly. And so when we were talking earlier about that whole vascular issues, it is a common problem that we see in our elderly population. And there's been lots of research around, especially through the International Lymphedema Framework. This is an older publication in 2012, but just to give you some ideas, over 65, 10% had chronic edema, over 85%, 29, so you can see it's increasing. If you've got a concurrent ulcer, 40%. In fact, we're seeing even more than that, than the 29% in that older population, because we're not getting to them all. So I think surveillance in this area is really important. Because, all right, there's lots of reasons for swelling, because I can hear people say, oh, yes, but it could be their heart, could be their kidney function, it could be whatever. And that's true, but it needs to be dealt with, because swelling sitting there is not helping the skin, more likely to break down, more likely to get an ulcer, more likely to get a wound infection, cellulitis, etc. And they're not all good things for elderly people to have, and will impact on their quality of life and their health. So this particular patient's 84 years old. She has a mixed vascular lymphedema. It's mild, you can see that, but it's important, just as important as the man in his 50s who reduced enormously. So she had long-standing swelling. She'd had a skin cancer removed from her right calf, so she felt her right leg was worse. And it's important for her to have compression, and that's what we did, a class 1 flat knit compression to manage her legs, to improve her skin and improve her basically the swelling in her legs. So it's fairly low, and this is another thing that it's important to remember. Obviously the right leg's slightly worse than the left, but because the swelling is mainly around the foot and the ankle, it does get washed out a little bit with the SOZO, or bioimpedance, I should say. So it's not that those high numbers, because it's taking the whole leg into consideration. We can explore this after the webinar a little bit more if people want to look at that, but still very relevant, because we can watch what's happening over time and making sure those spikes are not continuing to go north, which is important. My final client I want to chat about, and she was very keen to have her case study discussed, is a lady who has a mixture of lipo, lymphedema and obesity. She's 51 years old. She does have that mixture, and I think the lymphedema is mainly below the knee for a number of reasons that I probably haven't got time to discuss in this webinar. She, when I originally saw her, was 197 kilos, so she was an anaesthetic risk. She was going to have gastric sleeve surgery because she felt she couldn't just do it on her own. She, though, had taken that initiative to say, look, I have to do something about this. I'm heading in the wrong direction for my health, I'm only a young person, for long term. So she did get herself into a strengthening program, which probably ramped up more once she lost the weight. So with Pilates and utilising an exercise physiologist. And she had to make changes, not from only her physical, from exercise and the weight, but also her psychological perspective, because we know that a lot of people that are overweight, that have these forms of surgery, don't always have success stories later on. It is just as much the psychological management as the physical, and you have to be in that right headspace and be determined, which she was. So let's have a little look at her measurements. So you can see back in March 2015, she was 197 kilos, and then she started in December 17 looking at meal replacements pre-surgery, trying to get that weight down. So by the time she was January 2018, she'd had the gastric sleeve surgery. So when I saw her back in 2015, she knew she needed to do something about her weight, and the swelling below her knee we managed with wraps. And I really, after that, once she hit the surgery, I didn't see her until 2018 after that time. So you can see that she had the surgery, her weight started to reduce, and this year, 77 kilos. Across the board, her circumferences have changed from her waist to her hips, her upper arms, her thighs and her calves. So what does she look like? So there she is. There she is now. So it's quite dramatic, and that makes me also wonder how much the obesity was there rather than necessarily the lipedema as well. But it's quite significant, those changes, and well done to her. So when I saw her, and if you have a little look at where that weight loss occurred, So I started measuring her again in August 2018. She came back to see me, not because of her lymphedema, it's because her blood pressure had dropped with such a dramatic change in her weight. She found her blood pressure was low. So her GP said, well, maybe you do need some compression below knee, and which did assist. So we put her in a flat knee class 1 because of also her shape, that we knew that wouldn't cut in, and she found that very comfortable. She wanted the band at the knee just to make sure it held up. We've slowly reduced the size, and which has been fantastic. So, but if you have a look at where did she lose all this weight, and this is where just a BMI doesn't tell us anything, is clearly she didn't lose a lot of fluid. Skeletal mass didn't drop, so increase. So I think that's great, but it was the fat mass. You have a look at that. 42.9 is amazing. You know, I mean, wow, that is incredible. I asked her, actually, I said, I'm doing this presentation and I want you to, because she's continued to actually come to see me to do the SOZO. And I said, I'd like to know your feedback of why do you keep coming to be measured? And this is what she said. So I'd like to read this out because I think it's really relevant. Having lost a lot of weight over 24 months or so following a gastric sleeve operation, so 122 kilos, I became very dependent on external measures of my progress. Weighing in regularly gave me both an idea of my progress and the momentum to keep going. When my weight loss inevitably slowed down, and at times the numbers on the scales increased, I felt frustrated that I appeared to have one less external measure of my progress. However, given that my exercise activity was increasing along with my weight loss, my medicos reassured me that muscle weighs more than fat, and that the numbers on the scales were not the only measurement, or even the most important or accurate measurement of progress. Having regular SOZO tests then helped to provide me with a comprehensive, accurate and more in-depth gauge of progress, both in terms of weight loss, muscle build-up, fat-muscle ratio, but also in terms of overall health, improvements in terms of the fluid retention and lymphedema in my legs. And I think that's well said, that it is the whole person. And she really does find that reassuring and an incentive to keep going, which I think we need to understand that, you know, that's so much about how people have success, is if we can give them that positive reinforcement. So before I finish, I just want the opportunity to chat about group data. It was brought up at the last webinar, and version 3.1 has got it, which is fantastic. And I think this is really exciting because we'll be able to group by cancer, by type of lymphedema, type of surgery, type of chemotherapy, obesity, lipedema, vascular, and more. And we'll be able to look at our clients as groups and see what's happening across the board. It'll also be useful, perhaps as clinicians and impediment, to have a look at what the standard grouping should be, so we can talk between each other and be able to pull that data and have a good look at it, obviously de-identified, and have a sense of where our direction is going. So thank you for hopefully listening to something that has given you some information that is useful. It's an opportunity, and especially with the bilateral application, to take it and utilise it, and not just utilise the fluid aspect of it, but to utilise all those measurements. Otherwise, it's a missed opportunity to help our clients holistically. And really, if you can't understand all the information, and ImpediMed is here to help, then you can call upon those other people in your multidisciplinary team to assist you as well. So thank you for listening.